Um, Today I was asked to talk about learning theories behind experiential learning. If you're gonna look into that subject, perhaps by the end of this lecture, you're gonna learn about theories behind experiential learning and competency development, as well as you will be able to understand the role of simulation and virtual online simulation, in particular in medical education. So a classical medical education methods include mainly chalk and talk, which includes lectures, seminars, workshops, and others. Reading books means giving assignments, writing essays, and other things. And also see one, do one, teach one, which we call it apprenticeship model. A friend of mine also called this see one, do one, kill one. So that's the only way you learn practical knowledge at this time in medical education. Now, let's see which one of these methods are the best method. In the United States National Training Laboratories, research has shown that 3-month memory retention for lecture is about 5%. So in 3 months, you're going to remember only 5% of what I will say today. Reading is about 10%. When you add audiovisuals, it increases to 20, demonstration is 30, group discussion, which is like PBL and CBL, would be 50% knowledge retention. However, practice by doing is 75%, and teaching others is 80%. So it looks like see one, do one, teach one is perhaps the best method to learn. But how learning by doing occur? So learning by doing was first proposed by Swiss pedagogue Piaget, and he introduced the theory of constructivism. What Piaget said is learning is secondary to and dependent upon progressive reorganization of cognitive function. To learn, Piaget said, is not to reshape behavior, but to provide the environment for students to self-explore. A Russian pedagogue, Vygotsky, also very famous, agreed to the theory of constructivism with Piaget. However, he believed that if you leave a student with a computer or learning tools alone, they will not learn much, because he believed that learning is a social event. We learn from each other. That's why he came up with theory of social constructivism. At this particular time, using computers, of course, it's the student with the computer. Everywhere you're seeing that students are sitting alone with a toy computer learning. But however, you understand that computers are now, with the help of internet, become the biggest social creature ever. So with computers and learning platforms, we do provide the environment for constructivism and also for social constructivism. On the other hand, let's look at how we gain competencies. How do competent clinicians use their knowledge to arrive at a diagnostic and management decisions? Research has shown usually 4 types of thinking: reduced thinking, dispersed thinking, elaborated thinking, and compiled thinking. We're not going to talk about the reduced and dispersed thinking because we don't want to teach our students through these type of thinking. But elaborated thinking, on the other hand, is the most used in medical education. So elaborated thinking is mostly based on deductive reasoning. So what we do in the medical schools, we teach our students how to take history, how to ask specific questions, how those questions would relate to the pathology that you're investigating, how to formulate hypotheses, and how to do physical examination and connect signs and symptoms to those history points, and how to do differential diagnosis. So, and come finally to a conclusion, which we call final diagnosis. Now, this elaborated thinking is an outstanding method to learn, but it takes a long time to learn. Perhaps it takes a few hours for the students to come up to a diagnostic conclusion. However, when the students graduated and it goes to practice, after 3 to 5 years, if you go and visit that student who's already a doctor right now, he would come to a diagnostic conclusion within 10 minutes. It's not because he is now ignoring you. It's because he is working on a different level of thinking, which is called compile thinking. And compile thinking is based on recall, recognition, memory. What it means is that if within this 3 to 5 years of his practice, you have repeatedly saw and treated similar patient and repeatedly encountered with similar pathology, we will remember most of those pictures. And when the new patient comes, he will recognize that, his brain. So now this compiled thinking in recall, recognition, memory was proposed by Hofding. Now, before understanding this, we have to have another concept to understand. It is a concept of transfer of knowledge versus transfer of learning. Usually people confuse these two terminologies. Transfer of learning is from one person to another person. It's when I give knowledge to you and I'm receiving knowledge from you. That's transfer of knowledge. But transfer of learning is when, prior experience of your experience affect your present experience. It means transfer of learning is from the same person to the same person. My experience, past experience affects my future experience. That's what Hofding has discovered. There are different types of theory of transfer at this point. There's theory of identical elements and others, and due to the time constraints, I will not talk about those, but I will talk about the cognitive theory of transfer that relates to this subject. The cognitive theory of transfer dictates that the brain would choose the conceptually similarities, not the exact similarities for transfer of learning. What it means in very simple word, this is very complicated diagram, but I can simplify it for you. If you had a prior knowledge and experience, it goes to your short-term memory, goes to your long-term memory, and your hippocampus somewhere it saves. And then in that long-term memory hippocampus, you form a semantic neuron network, which consists of some of the cells and pathways between the cells. This semantic network would represent your prior experience. And when the new experience goes through the same short-term memory to long-term memory, then when through amygdala, it goes to hippocampus, the hippocampus would find out those semantic networks that are conceptually similar to your new one, not exactly similar to your new one. And that's why you can just go in faster problem solve. Chan actually did an experiment in published it in surgical simulation. This would perhaps clarify this a little bit more for you. Let's assume that these dots here is the neuronal network that I talked about. And if you, when you were a small little kid, your mother taught you how to tie your shoes. So you know how to tie shoes. Now you come to medical school and the teacher do the orientation for you on how to do surgical knot tying techniques. Now your brain, when he introduces this, your brain picks that, oh, similar to this you have done before. And now he builds on that similarities. And then when he coaching you and take your hands, then you build on that, bring more neurons in bronze, bring more pathways attached to that. And once these pathways, you repeat it many times, then these pathways and these neurons will turn slowly into a very solid new neural network, which is surgical knot tying techniques. And that's why you see when you see a surgeon making 100 knots in a minute, it's because he have been through all this. And this is how it happens. So what is the role of simulation here? So all these 3 levels of development with simulation can be done much faster, particularly in clinical education. So if you go back to classical pedagogical method of see one, do one, teach one, experiential learning would take a long time of repetition for years for you to gain compiled thinking and to become a competent physician. So therefore, what will happen in here, you see year 1, 2, 3, 4 years of residency training program, we go very slow to get to the point to become a chief resident and do independent work, that we trust you now that you are a competent physician or surgeon. So as a result, these obstacles that are on see one, do and teach one is patient availability, ethical issues, legal issues that makes the system slow. And medical education as a result of that is perhaps unsafe. And to make it safe, we have to make it slow. To make it ethical, we have to make it slow. And also it will be costly, and it's not very efficient, and it's unreliable. But if you introduce simulation, particularly online simulation, like such as CyberPatient, in your experiential learning, then you can condense this years of training and experience into a very short period of 2-3 months, and you could gain your compiled thinking that would improve your competency. As a result, you will bring this with simulation, you will bring that competency much faster to your students to work independently. And as a result, our medical education would be safe, ethical, cost-effective, efficient, and reliable. So to have a little bit of a summary here, we believe that all simulation methods, but particularly CyberPatient, will have a lot of pedagogical values for students. So particularly CyberPatient is a student-centered education. It's competency-based. It improves decision-making abilities. It improves experiential learning, enhances experiential learning, accommodate style of learning. So you can, through audio-visual learning, writing, clicking, it triggers all the memories. It improves compiled thinking and provides a solid base for transfer of learning. It also supports faculty, because I know as a faculty, I go around to find, when my students are coming to the clinic, I have to go and find a patient that is suitable for that class, and that the patients are not coming in my command. The patients are coming as they get sick. So we have always difficulties finding patients. But now with CyberPatient, we have a virtual hospital with 120 patients ready 24/7 to support the faculty member, to give an opportunity to give assignment to their students. It's also valuable for the university because it reduces the cost of education. Our research has shown that CyberPatient is 90% time less costly than the use of standardized patient for medical education. And it also benefits the healthcare system and the society as a whole, because repeating in a virtual environment and become competent in a virtual environment would make the system safer, would reduce the medical errors, and subsequently the cost of healthcare system. At this point, I hope it's 10 minutes or 15 minutes. I went very fast, so it's a very small portion of this, and I thank you very much for your attention. If you have any question, please ask me, and I will be able to answer if I can, and then you can continue with Mark and Dr. Shahriar.